Hello everyone, I welcome again to the second session now, which we are going to discuss today, that is the conduction system of the heart. We have discussed the functional anatomy of the heart in the previous video. Now we are going to discuss about the conduction system of the heart. So what is the conduction system of the heart is all about? It is about the conduction system from where the energy is generated or the impulse is generated. From there it is transmitted along a pathway and the entire ventricular muscles is also getting activated. So this process is called as the conduction system of the heart. If you remember, in the cardiac muscle I have told you that is the proper myocardium, and second one is the modified myocardium. That modified myocardium is nothing but our conduction system of the heart. Before going into this chapter, I would like to ask two questions, that is, why SA node is the dominant pacemaker? We will get the answer as we go through the lecture, but this is one important question, that is why the SA node is the dominant pacemaker. And next one is why the atria usually contracts ahead of the ventricle. So we will try to find out the answers for these also along the course of the lecture. So let's jump into the chapter, that is the conduction system of the heart. So first I told you it is the modified myocardium. So what is the modification? So there should be some modification rather than the other place, that is the ventricular myocardium. So first one is it has less contractile proteins. The contractile proteins like the actin and myosin, both are less in this region. Point number one. And next thing is it has less of organelles. The cellular organelles are also very less here. And it has a specific type of cell which is called as the P cell. What does this P term stand for? As the name indicates, we are going to study about one of the pacemakers. So P cell is nothing but a pacemaker cell. So P cell is pacemaker cell. That is one very good speciality about this pacemaker cell. So what is the importance of this pacemaker cell is it can generate its own rhythm. So that is why sometimes if the generation is not happening, when externally some battery is placed into the heart, that is also called as a pacemaker. And pacemaker cells are generating this impulse because of this P cells. And these P cells are not only present in the SA node, it is also present in other places. So I will tell you what other places this P cells are present. So first one is the SA node. Second, it is also present in the AV node. Third, it is also present in the bundle of His. Fourth, it is also present in the Purkinje fibers. I will tell you about all these terms in the next succeeding lecture, but as you can see here, it is present in multiple places, but still we all know that SA node is the dominant pacemaker. We'll find out the answer in a while. So next thing is, what is the conduction pathway? So where does it start, how does it move about, and where does it end? So first, this is the heart, and here we have the right atrium, this is the left atrium, this is the right ventricle and the left ventricle. This already we have seen it in the functional anatomy. And there is one major vein which is draining from the superior part, that is called as the superior vena cava. And another vein also will drain into the right atrium, that is nothing but the inferior vena cava. So these two are the veins which are going to drain into the right atrium. So this node which we can see on the right atrium, on the topmost region, where the superior vena cava is coming and draining into it, that node is called as the SA node. So what is its location? Near SVC, where the SVC or the superior vena cava is draining. So coming to the next node, as you can see here, which is in between the right atrium and the right ventricle. So what is this node? This second node is called as AV node. So what is the full form of SA node? SA node is nothing but sinoatrial node. Sinoatrial node. Then what is the full form of AV? Sino means it is the venous system. So veins are there and it is in the atria. So that is why sinoatrial node. And where is the AV node? As the name indicates, it is in between atria and ventricles. So what is the full form? It is atrioventricular node. That is the name of it. Then after the AV node, what comes is this big bundle, as you can see here, this is called as the bundle of His. This bundle is called as the bundle of His. And after bundle of His, we can see here it is divided into two branches. The one which is going on the left side is called as left bundle branch, and one on the right side is called as the right bundle branch. It's simple as that, right bundle branch. And finally, they are giving minute fibers. As you can see here, these are the minute fibers, and these minute fibers are nothing but Purkinje fibers. Purkinje fibers. So this is all about our conduction system. So these are the elements of our conduction system. First the SA node, and then the AV node. From the AV node, bundle of S, then right and left bundle branches, and finally the Purkinje fibers. And I already told you pacemaker cells are present in the SA node, AV node, bundle of S, and even in the Purkinje fibers. It is present in many places, but still SA node is considered as the dominant pacemaker. So coming to the next thing, there are some connecting fibers between the SA node and the AV node. As you can see here, whenever SA node is here, the AV node is here, there are fibers which are connecting them. So what will be the name of the fibers? It is connecting two nodes. So what is going to be the name? It is very simple, internodal. It is in between the nodes. So it is called as internodal fibers. Internodal fibers. And they are having three branches. One is the anterior. If any anterior is there, what is going to be the other one? The posterior. And whichever is in the middle, that is called as middle internodal fibers. So we have three fibers: anterior, middle, and posterior internodal fibers. And they have specific names also. So the anterior fibers, previously it was called as Bachman. Nowadays there is no name for it. So it is anterior fibers. So nowadays, which fibers we call it as Bachman? Nowadays, the Bachman fiber is given for the fibers which is in between two atria. So from one atria, some fibers are going to the other atria. For example, from the right atrium, some are going to the left atrium. So this interatrial fibers, interatrial, in between the atria, interatrial fibers are called as Bachman fibers. Then coming to the middle M, you try to reverse it, that is W, Wenckebach fibers. Then posterior fibers are called as Thorel fibers. So these are the three different groups of internodal fibers which are innervating between SA node and the AV node. So now let's try to understand what is the conduction rate, like how much impulse potential they can create. For example, if I ask you what is the normal heart rate, all of you will say that it is around the range of 72 and the range is between 60 to 100 is taken as normal. But who determines this rate? This rate is determined by the rate of atomicity of the various different pacemakers. So let's try to understand what is the different firing rate of all the fibers and their conduction velocity. What is this conduction velocity is? It is the rate of impulse which is conducted inside the node itself. It is not the rate generation. It is the rate at which the impulse is transmitted inside that particular node. So that is called as the conduction velocity. First, coming to the rate of automaticity of the SA node, it has the highest, that is 60 to 80 beats per minute. That is why most of the people have a heart rate around this range, 60 to 80 beats per minute. Then coming to the AV and the bundle of S, both of it will have 40 to 60 beats per minute. It is less than that. Then the third one is the Purkinje, which is around 20 to 40 beats per minute. Now coming to the conduction velocity inside the node, it is 0.05 meter per second in case of an SA node, and AV node is very low. It is 0.02 meter per second to 0.05 meter per second. It is very inside the AV node, the impulse is traveling at a very slow rate. It has also got a significance. We will try to understand that. And next thing is, we have the bundle of S, which is around 1 meter per second. It is fast. Whereas the Purkinje is the fastest. It is 4 meter per second. Again, the logic is that whenever the Purkinje fibers are giving impulse to a greater musculature of the ventricle, all the ventricles should contract at the same time, which we saw it as the syncytial property of the heart, wherein all the ventricle has to contract same time. So if it is giving at a very faster rate, then all of them can work and compress at the same time. That is why the Purkinje will have the maximum velocity. Whereas rate of atomicity, as you can see here, the SA node is the one which is having the highest rate of atomicity. So now the generation is done by the SA node. Under normal circumstances, the generation of impulse is done by the SA node, where the conduction is done by the rest of them, the rest of all of the fibers. So now we will understand why this generation is done by the SA node and why SA node is so superior, or we can call it as a dominant pacemaker. Let's try to understand. This is one of the most important concepts with regards to this chapter is concerned. So SA node is a dominant pacemaker. As you can see here, if you go through it, you can find the answer here itself. First one of the answer is it is generating at a higher rate. So since it is generating at a very high rate in comparison to the other fibers, the impulse is going to be produced from the SA node predominantly. So first reason is it is rate of automaticity. It is the highest. It is not higher also, it is the highest for SA node. Then there is a phenomena, second process, which is called as overdrive suppression. So what is this overdrive suppression? What is this overdrive suppression? I will tell you with an example, then it might be more clearer. Suppose we have a train, which is, imagine that this is a train with multiple boxes in it, and suppose it is connected to a car. Let's say the second one is a car, and suppose let's say it is connected to a bicycle, and let's say the train has a maximum speed which is around 250 kilometers per hour, and car a little lesser than that, let's say it's around 180 kilometers per hour, and bicycle at its least, which is 20 to 20 kilometers per hour. If these three are attached very tightly, what is going to happen? And the train is connected and the train is running at a maximum speed of 200 to 250. Now, if they are attached very strongly, what will be the speed of the car as well as the bicycle? All of them will be traveling at the speed that is determined by the train. Here what is happening is, since one person is having a superior or a maximal velocity, it is being charged at a very high rate. If the SA node is firing, even before the other nodes, even though they have their potential, even before they start to fire, the SA node's impulse will come again, and their only process in a normal chain of reaction will be to get the impulse from SA node and transmit to the next person. So this kind of suppressive activity, because of the increased speed which is gotten by the SA node, it is called as overdrive suppression. Because of its high impulse, the SA node is able to suppress the other nodes. Suppose if there is an ectopic in a heart, let's take if there is an ectopic beat, or an ectopic means any abnormal impulses which is being produced, and it is produced at the rate of 300 beats per minute. Let's say it is beating at the rate of 300 beats per minute. Can it suppress the SA node? Yes, obviously it is going to suppress the SA node, and that is why people tend to have arrhythmias. That is because whenever somebody is having a higher potential, then obviously they will suppress even the other nodes and the SA nodes. In a normal situation, the SA node is suppressing the other nodes. Because of this, it is having the dominant pacemaker activity. And the third reason is the SA nodal tissue, they are naturally leaky to so many ion channels. At the baseline, even at the baseline also, they are naturally leaky. Naturally leaky means they are allowing the ionic transmission to happen very easily. Naturally leaky to ions. This is one thing. And fourth one is the SA node RMP itself is at a more positive level. For a ventricular muscle, it is around the range of -90. But whereas in a case of SA node, it is around the range of -50 millivolt to -60 millivolt. So already it is in a better position or more positive, towards the more positivity. So all these characters of the SA node make it as a dominant pacemaker. Then what is the name given to rest of the pacemaker? Maybe the AV node, maybe the bundle of His, maybe the Purkinje fiber, and even the ventricular muscle. All of them can produce impulses, and they are called as ectopic pacemakers. Ectopic pacemakers. Ectopic means other than the original position. So that is the thing about other fibers and their potential. Now for example, let's say the SA node thinks to stop on one day, that is, it's not going to fire. Can an AV node take over and give the impulse of 40 to 60? Yes, it can do it. The AV node, now it will generate the impulse of 40 to 60. But since it was under suppression for a very long time, throughout the lifetime, what will happen is it will take some amount of time for the AV node to generate impulse and again make the ventricle beat. So this time interval will cause unconsciousness. Why it is causing unconsciousness? Now nobody is beating and the AV node is not generated immediately. So what is going to happen? The cardiac output is not coming and the blood is not going to reach the brain and the person will have unconsciousness. After that, when the SA node tries to beat immediately after a quite immediate sometime, then what is going to happen? This unconsciousness, the person will be awake again. So this process of losing the consciousness and gaining back again with the help of AV node, this entire phenomena is called as a syndrome, which is called as Stokes-Adam syndrome. So the syndrome here is Stokes-Adam syndrome. And this doesn't happen usually, and if the SA node fails to generate at an earlier time or an immediate time, what is going to happen? The person is going to lose his life because the blood supply to the brain is going to be compromised. But still the AV node can take over the function for quite a good amount of time. Many of the time, that is why even the SA node, if it stops for a very little period of time, then the AV node tries to save the person's life and by producing its own impulse of 40 to 60 beats per minute. I hope it's clear. These ectopic pacemakers, whenever it is present in abnormal locations other than the AV node bundle of his, wherever it is, then also they are called as ectopic pacemakers. Anything other than the SA node, we can call it as ectopic pacemaker cells. Then Stokes-Adam syndrome, we already saw SA node failure, AV node coming up, and there is a loss of consciousness period and a regain of consciousness. So we have done with all these terms, and now we will be talking about the duration of conduction, like how long it takes from the impulse to come from SA node to AV node to bundle of His, and bundle of His to the Purkinje fibers. So from SA node via the internodal pathway, what is going to happen? It is going to take 30 milliseconds. It is going to take around 30 milliseconds. And when it reaches the AV node, for example, let's say SA node's impulse is coming from above and it has come to the AV node. This AV node has one special property. It will not give the impulse immediately to the bundle of His. It will wait with the impulse for some time. So this delay is called as AV nodal delay. This happens normally and this delay is around 90 milliseconds. I will tell you what is the significance of this delay. Of course, it is helpful for us. And then from there, it will reach the bundle of His, that is the ventricle area, in 40 milliseconds. So what is the total duration? Now it's around 90 plus 30 plus 140. It's around 160 to 170 milliseconds. The impulse from SA node will reach the ventricular muscle area. And from the Purkinje, I told you it has a very faster conduction rate. In just 50 more seconds, milliseconds, what is going to happen? The entire ventricle is going to get the impulse and it is going to discharge. Just from the SA node, entire ventricle will get discharged in just 220 milliseconds. It's a very small short span of time. And all these events, we are talking it slowly, but it is going to happen at a very rapid rate. So this is the entire duration of the conduction impulse traveling through the musculature. And now we will talk about the significance of this AV nodal delay, why it is important. That will give us the answer to the next question, that is why the atria contracts ahead of the ventricle. For example, what is the purpose of a ventricle? The ventricle's purpose is to supply blood to the entire body. If it is a left ventricle, it will supply it to the entire body, or if it is a right ventricle, it will supply it to the lung for oxygenation. But before that, the blood has to be filled properly in the ventricle so that it can pump and it can supply it to the rest corresponding areas. So what should happen first? First, blood from the atria has to reach into the ventricle. So first, who has to contract? The atria has to contract and the blood has to come into the ventricle. If the atria has to contract, what should not happen? The impulse should not come immediately to the ventricle. Otherwise, what would happen? Atria and ventricle, if both of them are like this, atria is also contracting and at the same time, even the ventricle is contracting. So blood, instead of going into the aorta or the pulmonary circulation, what is going to happen? They are going to go up and down between the atria and ventricle, which is not going to be of any help to the person and it will be deleterious. So what should happen? The atria should contract first, empty its blood, and then the ventricle has to contract. So what happens is whenever the SA node is firing, initially the atria will get its impulse. The discharge impulse will come to the atria and there will be an atrial contraction. Whenever atrial contraction is happening, the blood from the atria will come to the ventricle of the both sides. And at this time, what is happening? The AV node has been keeping the impulse and waiting, and it is acting like a gatekeeper. So how it is acting like a gatekeeper? Because the impulse is coming, it will keep the gate and wait for the atria to contract. After that, it will generate or give the impulse to the bundle of vessels. So AV node is also called as the gatekeeper. AV node is also called as the gatekeeper of the heart. So next thing is, after this 90 milliseconds delay, it is going to give the impulse to the ventricle, and now when the ventricle pumps in, the tricuspid or the AV valves are going to close, and then the blood will be strength corresponding to the corresponding area, that is the pulmonary circulation or the systemic circulation. So the atria contracts around 1/6 ahead of the ventricle. And why is this happening? Because of the AV nodal delay. And what is the reason for AV nodal delay? I have already given you a hint. The AV nodal conduction velocity, I am not talking about the autorhythmicity, it is the conduction velocity inside the fibers is 0.02 meter per second or to 0.05 meter per second. It is going to be very, very slow. And why it is slow? Because it has very less number of gap junctions. If the gap junctions are more, the conduction is going to happen faster. But it will have smaller cells and less number of connections between the cells. So because of this reason, the atria can contract ahead than the ventricle. So as you can understand here, from the SA node, the ventricles are getting impulse only through one way. From the SA node, it has to pass through the AV node, and then only the ventricular muscle will get its supply. Can anything happen abnormally? Normal condition, this is the only pathway, that is the AV node is the only one-way conduction. It is also called as one-way conduction. Under abnormal condition, can there be formation of alternate fibers between atria and ventricle? So there is a special syndrome. I am not going to reveal the answer. So you can put it in the comment section that when some abnormal fibers are connecting between the atria and ventricle. Here I will put you two questions. So what is the syndrome called? What is the syndrome? Second question is, these bundles, the abnormal connections between the atria and ventricle, they have a special name. What is this bundle name? I was about to reveal it. What is this bundle name? So these two questions you can put it in the comment section. Before starting the next session, I will give answers for this syndrome and the bundle name. Whereas in general condition, the atria and ventricle, everywhere there is no connection between them. There is a fibrous septa or a fibrous tissue which is present between them, and only through the AV node the conduction can be conducted. So this condition which is having additional fibers is an abnormal one. And what is the name of the bundle and what is the name of the syndrome which is behind this? And when we are reading an ECG, because of this there will be some abnormal changes also. Don't worry, that you can read it later, but you should know about the syndrome and the bundle name by the end of this session. You can drop in the comment section. I will give the answers before starting the next session. I hope you enjoyed the session. Thank you for watching. We'll see you in the next video. Thank you so much.